had heart disease at the age of 52 and ended up getting stents in his heart, then certainly that's an important thing. And the numbers are that if you have a first-degree female relative, mother, sister, under the age of 65, or if you have a first-degree male relative under the age of 55, that's considered an important family history, okay, and so forth. So let's talk a little bit about, you know, if you have these symptoms, and certainly if you have anything like that, the discomfort in the chest. Sometimes it can be associated with a vague feeling in your left arm, your left shoulder, sometimes numbness and tingling of your arm, sometimes a feeling going through to your back, sometimes unexplained sweats, lightheadedness, queasiness, or a nausea type sensation. Over the course of the past 25 years, I think about the women that I've taken care of with heart disease. And nothing personal to anybody in this room, but I just don't trust the symptoms. There was another lady, ICU bed 1, about 10 years ago, out at some auction, had 2 hot dogs, and she came in. Thank goodness the emergency room doctor was astute to recognize this, but she said, you know, here we are examining Dr. Zakreski, there's a patient in room 1, we want you to see something not right about her story. And she's convinced, it's the hot dogs, I shouldn't have eaten that, one of them had onions on it, and so forth. As I'm watching the ST segments, the part on the monitor going up, meaning that she's having a heart attack in front of me, and still convinced. I can't tell you how many, whether it's men or women, that sit at home because, oh, it was that hoagie I ate, or, you know, when I was working on the car yesterday, I was pulling something, or the way I was running the vacuum cleaner, I must have pulled a muscle in my chest, and they sit at home, and, well, I would feel, and then I hear, why did you wait 6 hours, 8 hours? Well, I felt foolish coming into the emergency room, and I tell them the only person who is foolish is the one who sits at home having a heart attack. And it's easy enough to do. You know, I don't want to, you know, for us to make sure you're not having a heart attack, obviously to do an EKG, somebody to examine you, to get a pertinent history, and to check some blood tests. You know, most of the time, you know, the way healthcare is now, we want to see the patients as quickly as we can in the emergency room. If we feel that they're low risk, meaning not having a heart attack, not having significant problems, get them to go home and follow up with their family doctor. Or the worst that happens, look, the story is suspicious. You'll buy, you know, 16 to 24 hours in the hospital so that we can check some blood tests. And these are the kind of things that I want you to pay attention. Most of the time, I tell my patients, anything from your neck to your belly button, shoulder to shoulder, think heart first, okay? You know, because that's the most important thing, whether it's going to be a heart attack or whether, you know, some of the other life-threatening problems. Hi, good morning. Other life-threatening problems like a blood clot to the lung or some problem with the aorta or something along that line. These are the kind of things that I certainly want you to pay attention to. Obviously, the risk factors, whether it's high cholesterol, high blood pressure, smoking cigarettes, and I hope nobody in the room smokes. That's the one thing that, you know, when I sit back and I think, what risk factor, you know, really sets up the red flag? You know, which one is most important? Everybody wants to know. Well, they can vary. Somebody who comes in is telling me they've been smoking 1 to 2 packs a day for the last 30 years. Well, you know, they're going to have not only disease in the coronary arteries, but the neck, the legs, and they'll be complaining of other symptoms relative to that. Certainly high cholesterol, and we have patients who have familial problems with their cholesterol, meaning despite exercising, despite dieting, despite everything else, they're just born, something passed down from mom or dad or something remotely where the body makes too much cholesterol, or the body just doesn't have the enzymes to break down the cholesterol. And as that goes on, as that continues, the effects of LDL, the bad sticky cholesterol, can certainly take their toll. Just a little bit more about cholesterol. Certainly, I hope everybody in the room will get your blood tested today, or at least you know what your number is. And remember, the total cholesterol should be under 200. Let's take a few minutes and just talk about the subfractions when we talk about LDL, triglycerides, HDL, and the total cholesterol. Which number is the most important? What should I be worried about? Well, they're all important, but I can tell you right now, today, as of November 6, 2012, the guidelines are based on the treatment of LDL cholesterol, low-density lipoprotein, and we try to keep that number as low as we can. Now, there are different goals for different subsets of patients with LDL cholesterol. Like I told you, HDL, think healthy cholesterol, you want it high. LDL cholesterol, lousy cholesterol, you want it low, okay? You want the LDL as low as you can. And I'm sorry, I'm back to, I have a bunch of things to show you and so forth, but this is something I could pass around to everybody. This is the inside of an artery. And you can look at there's a normal where there's none of that yellow, fatty streak, plaque, and so forth. And as time goes on, it progressively leads to more of that. Do you mind passing this around? You can take a look. I have a bunch of stuff for show and tell, if you don't mind. So the guidelines, there's a National Cholesterol Education Program, and they are the people that send the message to doctors, cardiologists, primary care providers, and other health practitioners what the goals should be, okay? So let's start out. If you are considered a low-risk person, meaning you don't have high blood pressure, you don't smoke cigarettes, you don't have a family history, your LDL cholesterol should be under 160 with an optimum goal of 130 or less, okay? That means for the safest of the patients. Then there are those patients that have risk factors. Suppose you have high blood pressure or a significant family history or smoke cigarettes. The LDL cholesterol should be under 130 with an optimum goal of 100, okay? And then suppose you're somebody who has more complicated or established heart disease, meaning you're somebody who's had bypass surgery or a stent or carotid surgery or peripheral vascular disease. We want that LDL cholesterol as low as you can get it, under 100, with an optimum goal of 70. There's many of the patients in my practice that I want to keep that LDL, which is the bad sticky cholesterol, to 70 or less. If there's less of that bad stuff floating around, less chance for this plaque and blockages to build up. And that's what our hope is today, to make sure we get that. How do we get the cholesterol down? Okay, the cornerstone is certainly diet and exercise. And one of the important part of that handout is what can you be eating? What can you be doing better with your diet? And I typically ask my patients, what are you eating for breakfast? What are you eating for lunch? What are you eating for dinner? What do you eat before you're going to bed? How many times do you go out and eat? Out to restaurants or get takeout and so forth. And then we try to work and say, you know what? Instead of those bacon and eggs in the morning, could you have Cheerios and low-fat milk and oatmeal, and try to avoid the donuts and pastries and how many times we hear people, but it's I just have to rush around and I get a bacon, egg, and cheese on a bagel or something like that for breakfast. And at lunchtime, I never have time. I'll just grab a Lebanon bologna and cheese sandwich. I said, no, couldn't you be doing, let's try talking about more turkey or tuna with light mayo and no potato chips, no tasty cakes, and those kind of things, and say, okay, and then at dinner time, trying to be more careful, more chicken and fish, and avoiding the gravies and fried foods and vegetables and so forth. And the same thing at nighttime, not snacking on ice cream and so forth. And these kind of things, it's not that hard when you say, could I be doing something better? When you go to put something in your mouth, you have to ask yourself, how many calories, how much fat, how much cholesterol, how much salt or sodium, okay? Is this good for me? Do I really want to eat this and have it, go to those love handles and so forth? And just trying to do a better job with that. The second part of treating the high cholesterol is certainly not diet and exercising, okay? And the American Heart Association, right in those guidelines there, 150 minutes a week of moderate intensity exercising, trying to get you to walk for 30 minutes a day, 5 days a week, 40 minutes a day, 4 days a week, or something along that line. And typically with women, and why I'm so happy to see this, we know that women, the last person they take care of is themselves. Okay, it's always their spouse or their parents or their kids or everybody else in the family, and who gets shortchanged. The woman who's sitting with me in the exam room is telling me about how I have to take care of mom and how my children are doing this and I'm running for that. I'm trying to hold down a job and my husband is doing, he doesn't have time for me and all this kind of stuff. And I say, you got to be selfish. You got to say, I'm here. I'm the one. If I'm going to be around to take care of everybody who's important in my life, I got to start taking care of myself today. Okay? And that means, like I said, with therapeutic lifestyle changes. And I love this phrase because it's TLC. And I want you to think about that for yourself. Therapeutic lifestyle changes. And the cornerstone of that is dieting and exercising. Okay? When diet and exercise doesn't work and the LDL cholesterol remains elevated, the next thing is putting you on cholesterol-lowering medicines. And I'm sure either you or somebody in your family or somebody you know have been on one of those statins, whether it's Zocor or Lipitor or whatever, and they can't take it. It causes muscle aches and so forth. But when we look at why the incidence of heart disease has gone down over the past 25 years, I think statins are going to be recognized as great drugs that have helped make a significant impact on recurrent coronary heart disease and so forth. So I think I do use them and I try to tailor them. I know some of them are stronger. You may have heard of the names, whether it's simvastatin, it used to be Zocor, atorvastatin, used to be called Lipitor. The good thing is these are both generic and the cost of the medicines has been beneficial with that. And Crestor, which is not generic, are three of the more potent, stronger ones. When you have more potent medicines or stronger medicines, the risks of side effects also go up, whether it's muscle aches, whether it's liver function study abnormalities, and the other things that you might be hearing in the press about. They might have an adverse effect on diabetes or cognitive function or memory and so forth. But we make that decision, weighing the risks and the benefits. What are the benefits? We know lowering that LDL cholesterol saves lives, reduces heart attacks, and so forth. The risks, obviously the cost of taking medicines, blood tests, and so forth. But certainly if you are one of those people who have high cholesterol and need therapy, then this class of medicines are very good. If you can't take statins, there are alternatives. There's a medicine called Zetia, not as strong as some of the statins. And there are other medicines, binding agents, and so forth. The topic of fish oil comes up often. Is that going to help lower my cholesterol? And really, fish oil are primarily for lowering high triglycerides. Okay, they help a little bit with the cholesterol, but I don't want you to think if my cholesterol is 250 or 260, I'm going to get it down to 200 with taking 2 fish oil capsules a day. It just isn't going to happen. I know when I start these medicines, I know what kind of reduction I can expect. If I put you on, a very strong drug like Lipitor, 40 milligrams a day, I'm going to take that LDL cholesterol of 250 and bring it down to about 150. I'm going to lower it 100 points. And I know with other drugs. And if you just have like a mild elevation in the cholesterol, say it's just at 250 and I want it to 200, I only need a 20% reduction in your cholesterol, and I can get that with a less potent medicine, something called pravastatin or Pravachol at a very low dose, 10 or 20 milligrams a day. So the doctor, when he's making this decision, is anticipating what kind of result he's going to get and why this drug is right for you. The other important thing I'd like to talk about as far as cholesterol-lowering medicine, oh, here it goes. All right. Can you see this okay? This is the inside of one of those arteries that I'm passing around. So we're taking artery out of the heart and put it in a cross-section area. And this is a little bit of that plaque, that fatty streak. This might be a 20%, 30% blockage. Okay? And remember, we identify the blockages at the time of cardiac catheterization. And one of the important things is somebody says, how could I have a heart attack? I just had a stress test, or I don't have any other risk factors. And this is an important concept in having a heart attack. Most people think that a heart attack occurs when this artery becomes filled with the plaque and cholesterol and all those kind of things like that, that little thing that I'm passing around, when that whole gemish of yellow goo inside the artery blocks up the artery. But most of the time, that's not what happens. There's something called plaque rupture, okay? And this is an important concept and why statins and other medicines help a lot, okay? And what we try to do is to prevent this plaque rupture. If we could find out, those of you in the room that have what we call the vulnerable plaque, the plaque that's at risk for rupturing, then we would really make an impact identifying those you people that might have that and help preventing heart attacks. What happens is, if you look at the normal artery here like that, where the plaque and all the other things that build up in the artery, there's a weakness, oh, there goes my good piece of chalk, a weakness right here, okay? It's called the shoulder of the artery. And it's where the abnormal part of the artery meets the normal part. And in that area, there's this weakness that can split or fissure or crack. And what does the body do when this area creates a little crack here? It calls in together platelets, okay? Platelets are the thing that cause our blood to clot if you cut yourself and so forth. Well, on the inside of the artery, the same kind of thing happens. And what happens is somebody has this, exaggerated response, and it fills up the artery with these platelets. And that's why, if you had something like this that happens, having had a heart attack and so forth, getting to the hospital right away will help because, number one, the medicines that we use are all blood thinners, and that's why aspirin works, right away. We want you to take aspirin. Why other clot-dissolving medicines work, why we can go in there with a balloon and open up that artery. So that split or fissure or crack rupture. And the reason why, the next thing that I want to get to is, how can we identify this? It would be nice if we could look at the arteries. We can't do that. Stress test will be normal if we do that in somebody like this. But the newest concept is the role of inflammation. And one of the things in the handout, they talk about people that might have rheumatoid arthritis or lupus or other chronic inflammatory states, such as fibromyalgia. They have a condition where they have an increased rate of inflammation. And there's a blood test out there that's very important in women called high-sensitivity C-reactive protein. And high-sensitivity C-reactive protein is a marker for inflammation. So the good thing about HSCRP, or high-sensitivity C-reactive protein, it might help identify some of these people who have low levels or low-grade inflammation in the arteries of the heart. The bad thing about it is it can happen with a lot of other chronic conditions. If you have rheumatoid arthritis or lupus, other inflammatory states, if you have gingivitis, if you have an infection, if you have a cough, or you have a urinary tract infection, or you have some kind of muscle ache or something like that, that can all raise the high level of HSCRP. And so we know that that's another important blood test that may play a role in helping identify women who are at risk for heart disease. So the other, let's just talk about HDL cholesterol. HDL cholesterol, the healthy cholesterol, we want it high. Unfortunately, there's not a lot of good medicines out there that help raise the HDL cholesterol. Niacin, which is one of the B vitamins, has been shown to raise the HDL cholesterol. We know that dieting and exercise also raises the HDL cholesterol. Okay. HDL, there are some people that talk about the ratio, the total cholesterol to the HDL. If your total cholesterol is 200 and the HDL is 40, your ratio would be 5 to 1. It's another way of looking at the total numbers and the relationship of the two of them. HDL is important where there are some great drugs on the horizon. Merck is working on a drug. Pfizer and another company tried to make a drug, but it had side effects that helps raise the HDL cholesterol. For those of you that might have very low HDL, 25, 30, 35, this drug doubles it, 60, 70, 80, and so forth. Unfortunately, we're not sure if using medicines to raise the HDL correlates to reduction in coronary events. Okay, there was one study that just recently completed said, yes, we gave a drug like niacin, we raised the HDL, and we followed these people out 5 years, and guess what? Even though they had higher HDLs, the incidence of heart disease was about the same as in the control group. So the HDL hypothesis has lost a little bit of steam, and hopefully it will help some of the patients that worry about having a low HDL cholesterol. Doesn't mean that we don't recognize it. We don't look at it. We don't talk about it. We try to, use hygienic measures and so forth. Triglycerides are one of the other fats in the blood, a little bit less important than LDL, HDL, and total cholesterol, but another thing that should be tracked. Their value should be under 150 for the triglyceride level. I could talk a little bit about high blood pressure, especially in women, but later today, Dr. Kranak, my partner, is going to be talking about high blood pressure. Certainly, normal blood pressure, 120 or 80 or less. High blood pressure, 140 over 90 or greater. Intermediate or borderline high blood pressure is anything from 120 to 140, 80 to 90. Lower is better. Lower is always better when it comes to cholesterol, blood pressure, and so forth. Just a quick point about high blood pressure. The main reason that we treat it is not because you're in the doctor's office and you're fighting traffic and the doctor was an hour late and you're sitting there and you have things to do. Your blood pressure is 150 over 95, too high. And we know there's a white coat effect, and we do recognize that. And that's why I ask my patients to check their blood pressures outside. A lot of good cuffs, whether they're the arms or the wrist or so forth, to have available. Because if you go into the doctor's office, oh, geez, Mary Jane, it's 150 over 95 today. But Dr. Zakreski, it's never like that when I check. That's important to me, and it's important to all the doctors. Because remember the effects of high blood pressure and why we treat it. Not because of that isolated number taking there, but the effects that high blood pressure have long-term on your eyes, on your brain, on your heart, on your kidneys, on your blood vessels. We don't want to be, when you're 60 or 70, treating you for congestive heart failure because years before your blood pressure was persistently elevated. And it's a relatively simple plumbing concept. If the heart has to work to pump the blood 180 to 200 millimeters, it has to work harder. It has to work harder to pump. And when that happens, like any muscle in the body, the muscle increases in thickness. The heart becomes thicker, it becomes enlarged. And initially that's a good thing for us to compensate for that. But as time goes on, the heart squeezes okay, but it can't relax. It gets stiff. The relaxation properties of the heart are just as important as the squeezing function of the heart because of the ability of the blood, whether from your legs or your lungs, to get back into the heart. If it can't get into the heart because the heart isn't relaxing or the heart is stiff, backs up into the lungs and leads to a condition called congestive heart failure, fluid in the lungs, swelling of the legs, and so forth. And those are the kind of reasons why it's very important to treat your blood pressure now or when you're young, so that down the road you're not talking about more serious complications. So high blood pressure, high cholesterol, certainly diabetes, and getting the diabetes under control. When patients come in to me, they're, say, 55, 60 years old. Dr. Zakreski, I've been an insulin-dependent diabetic since the age of 17. Another red flag goes up, okay? Certainly, the long-term effects of diabetes that affects every blood vessel in our body, and certainly the coronary arteries, the arteries of the neck, putting you at risk for stroke and so forth. We are trying to get more aggressive. That's why the numbers for cholesterol, about 10 years, for glucose, used to be anything under 110 was good. Now, the normal is under 100. And the reason is we want patients who have blood sugars of 108 or 109 to say, hey, you know what? I'm in the borderline diabetic range. I have to start doing a better job, whether it's with diet or exercising and so forth. Normal blood sugars under 100, high blood sugars over 126. Between 100 and 126 is considered borderline diabetes. And then they look at other numbers. There's something called the hemoglobin A1C, or glycosylated hemoglobin. That's a pretty neat test because it tells you about blood sugar control over the past 3 months. So sometimes your fasting blood sugar in the morning might be normal, but as the day goes on, your blood sugar creeps up. And this hemoglobin A1C tells us how your blood sugar has been controlled over a longer period of time. And that helps with that. So the 4 major risk factors, okay, diabetes, high blood pressure, high cholesterol, and tobacco usage. Certainly, whatever you can do to make sure that those risk factors are under control. Can't do anything about your family history other than recognizing you're at risk and so forth. So we talked about that. There's a bunch of other things, coronary heart disease and so forth. We know that women, like I said, paying attention to the symptoms, women, a routine stress test. Let's just talk about testing a little bit. How do we find out? Do you have blockages or so forth? Certainly a stress test, symptoms, good examination, obtaining a history, looking at the whole risk factor and so forth. Then the point may come to do a stress test. Now there are different kinds of stress tests. A routine stress test is just we hook you up to an EKG monitor, put you on the treadmill, have you walk as long and as far as you can, and look at exercise tolerance, blood pressure response. Do you develop cardiac arrhythmias or irregular heartbeats? Importantly, are there changes on the EKGs suggesting that the heart muscle is not getting enough blood? Unfortunately, women often, because of hormones, estrogen, progesterone, and so forth, often develop a positive stress test, a positive routine stress test, meaning that the ST segments, things that tell us if there's signs of blockage, are abnormal. And more often than not, it's a false positive. So we have to do something to increase the predictive accuracy or sensitivity and specificity of the test. So we often do an imaging, some type of imaging agent. A very safe test to do is called a stress echocardiogram. An echocardiogram is an ultrasound. We put a probe over your heart. We look at the pumping of your heart. We look at the valves, how they open and close, and then put you on the treadmill. Walk on the treadmill immediately when you're done exercising. When that heart is still beating 150, 160 beats a minute, take pictures of your heart. And we can see if there's blockages, the heart muscle won't squeeze as well. Okay, and that's one of the ways, especially in women. There's something called a nuclear stress test where we inject an isotope. The isotope goes to the heart muscle. If there are no blockages, we see a nice rounded picture like a donut, if you will. And that means that all the arteries are supplying the heart muscle with adequate blood flow. If you have the start of a blockage when you're walking on the treadmill, because the blood can't get through the blocked artery, it'll look like a donut with a bite taken out of it. And that will tell me that, say, the front part of the heart is not getting enough blood flow when you're exercising, and that would mean that there's a blockage. And then the next step is the cardiac catheterization. Cardiac catheterization is what we call the gold standard test right now for identifying blockages in the arteries of the heart. Most of the time these days they put a small catheter about the size of a piece of spaghetti or something, and goes up into the heart, and they inject dye into the arteries that surround the heart. You can see as the dye fills, and then there'll be like a narrowing or a pinching or a napkin ring deformity, we call it, that there's an evidence of a blockage there. And depending again upon the history and physical examination, stress testing, the doctor who's doing the test will make a decision. Do I open up that artery and put a stent in, or do I do nothing? And the decision will be the severity of the blockages and so forth. In this day and age, most of the patients are getting a stent. A stent is like an internal scaffold that holds that artery up. And there are two kinds of stents, and it's important to know if anybody in your family has them. One is called a bare metal stent. That means it's just a plain old stent. Another very important stent is called a drug-eluting stent. What happens with the bare metal stents, the first one I said, is that's stent which is like a meshwork, if you think of the inside of a pen or a spring or something like that. But what happens when the body sees that foreign body inside the artery, it reacts by saying, let me lay down a callus, or smooth it out, if you will. And in some people, that callus can form and grow and narrow that stent up. In a drug-eluting stent, somebody was smart enough to say, hey, that callus formation, let's put a drug in there that prevents that callus from forming. And it keeps that artery open a longer time. When you have a drug-eluting stent, you have